Massive transfusion protocol. So, massive transfusion is generally defined as requirement of more than 10 units of PRBC in the first 24 hours of injury. It is more common in military. Almost 10% of military trauma require it, while only 3 to 5% of civilian trauma requires it. Massive transfusion has 7 T's. First is trigger MTP, then team preparation, Trenexa, test early, transfuse to target, temperature management, and terminate the protocol. What are the triggers? So the trigger when you will start a massive transfusion protocol is when the mechanism of injury, the patient has penetrating trauma, because penetrating traumas cause vascular injury. The blood pressure is less than 90 millimeters of mercury. There is positive fast and the presence of 2 or more variables that has and pulse rate more than 120. So 4 things are required: penetrating mechanism, BP less than 90, pulse rate more than 120, and a positive fast. So the triggers for activation are pre-hospital, such as concerning mechanism, penetrating trauma, shock index more than equal 1. Initial ED assessment, there is a RABT score of more than 2, ABC score of more than 2, shock index more than 1. During resuscitation, if the patient is requiring more than 2 units of PRBC and still the patient is unstable, you need to start a massive transfusion protocol. You can start it early in a patient who are elderly, were on anticoagulation, they had beta blockers. So prepare the team. Early notification and prepare the extended team, who all are included in the team: your emergency department team, your labs, your blood bank, and your trauma surgery unit. So what happens is, when you make a decision of a massive transfusion protocol, you need to draw all the samples immediately, because after the transfusion the patient will have a lot of donor blood and the results won't be what we want. Especially blood cross matching, draw it ASAP. So early you need to maintain CBC, INR, fibrinogen, calcium, potassium, lactate, VBG, PTT, blood group, and blood screening. Next, administer tranexamic acid. In trauma, initiate within 3 hours, 1 gram IV over 10 minutes, then 1 gram TDS. GI bleed में no evidence is seen with tranexamic acid. In fact, there is a harm also. So Trenexa is for trauma, not for GI bleed. Then there is temperature. Target is more than equal 36 degrees Celsius. As we know, hypothermia causes coagulopathy. Remove the wet clothing. Provide warmed IV fluids and monitor temperature hourly. What are our targets? Hemoglobin more than 8, platelet more than 50,000, INR less than 1.8, pH more than 7.3, lactate less than 4, and calcium more than 1.15. As you know, calcium is a clotting factor 4 in our body, so we need to supplement calcium with every blood products. It's going to chelate, as well as there is an increased coagulopathy with hypocalcemia. Then there is a termination of massive transfusion protocol. When to do it, how to do it, we'll discuss. So they say that the ratio of PRBC to platelets to FFP should be 1:1:1, but no optimal ratio is known. When we start an MTP, we need to do investigations, get IV access to large bore IV cannula or central cath, blood type and screen, CBC, platelet, INR, PT, PTT, fibrinogen, electrolytes, burn create, ionized calcium, monitor urine output, acid base status, and vital signs. Aggressive rewarming is required, prevent acidosis, correct hypocalcemia, give calcium gluconate or chloride. If you are giving chloride, give it via central line or via slowly, as it is a high osmolar content and it can burn your peripheral cath. Target goal ionized calcium is at a higher side, 1.2 to 1.3. If you repeat lab testing to evaluate coagulopathy and stop the crystalloid, avoid dilutional coagulopathy, avoid diluting the already present coagulation factors in the patient's body. If the patient was taking some anticoagulant, we need to salvage the patient, give heparin reversal, which is protamine, 1 mg protamine IV for every 100 unit heparin given. you will give warfarin reversal, vitamin K 10 mg IV, or you can give prothrombin complex concentrate. It contains factor 2, 7, 9, 10 protein CNS. Chronic renal failure or von Willebrand disease. If you're suspecting CKD or von Willebrand disease, both of these cause platelet dysfunction, so we need to give desmopressin, which is 0.3 microgram per kg IV, 1 dose. Trenexa is given 10 mg per kg IV, remember that. And the patient, if the patient was on streptokinase, then we need to give epsilon amino caproic acid, Amicar, 5 gram IV bolus, then 1 gram per hour infusion. So general guidelines for lab-based blood components replacement. So when to replace, how to replace will based upon the lab results that you will get. For RBCs, there is no threshold. It depends upon the doctor whether the blood needs to be transfused or not. FFP is transfused only if INR is more than 1.5 and 4 units are given. Platelet less than 1 lakh, 1 5-pack platelet is given, and cryoprecipitate is given as fibrinogen is less than 100 and 2 5-pack, yani total 10-pack cryoprecipitate is given. So fibrinogen less than 100, you will give 10 packs of cryoprecipitate. Meanwhile, we need to stop the ongoing bleed by surgery, angiography, embolization and endoscopy in GI bleed. In adult, if the requirement of 4 unit RBC in 4 hours and there's still ongoing bleeding, it is massive transfusion protocol. So clinical team activates what we need to provide to the blood bank: the name and the clinical contact person to the blood bank, patient's name, location, call of donor, and send the person to pick up the cooler. Ensure that then patient को cooler लेके भेज देंगे. Blood bank prepares MTP pack which will be transfused as a 1:1:1 ratio. Of course, you will transfuse the platelets first, then the FFP, then the PRBC, because platelets सबसे जल्दी ख़राब होते हैं, and FFP आप जल्दी transfuse कर सकते हो without worrying about the reactions. So the MTP pack contains, MTP cooler contains RPF, Railway Police Force, 6 unit RBC, 5 unit platelet, 4 unit FFP. You will transfuse the 6 unit RBC, 5 pack platelet, 4 unit FFP. The patient recovers, well and good. Notify the blood bank and return all the remaining products. If the patient is still worsening, repeat the labs: CBC, platelet, PTNR, PTT, ABG, fibrinogen. Assess the calcium, potassium, lactate and hematocrit. And clinical start, call the blood bank for another MTP pack, and you can adjust the amount of amount of blood required, like need more PRBC and you don't need platelets, or you need FFP only, no PRBC, that you can tell the blood bank. Consider recombinant factor 7A if there is a persistent coagulopathy, which dose is 90 micrograms per kg. Recombinant factor 7A, PT, will be raised in factor 7 deficiency. Then there is a thromboelastography, and we also use rotational thromboelastometry called ROTEM. Why we need TEG is because our coagulation is a result of 80 complex reactions, and no blood investigation can actually tell us about everything. So thromboelastography is one such which will help us differentiate which will help us tell what is the cause of bleeding. So to remember the components of TEG, we need to remember a mnemonic: Ranbir Kapoor alpha male. So R is the clotting time, K for Kapoor is the clot formation time. There is alpha angle, which is rate at which fibrin cross-linking starts. May is maximum amplitude, which is maximum strength of the clot, and LY30 is the degradation of clot 30 minutes after maximum amplitude. So R is enzymatic reaction, which is starting of clot, then K is polymerization, and after that, after LY30 maximum amplitude, there is thrombolysis. So normal appearance, as you can see, looks like this. If there is a hemodilution or clotting factor abnormality, if there is a clotting factor deficiency, the K value will increase, so the clotting will start late. If there is a fibrinogen deficiency, then the strength is polymerization is less, so the alpha angle is less. What is the treatment of hemodilution or clotting factor deficiency? You need to supplement the clotting factor, and all clotting factor are present in fresh frozen plasma. And fibrinogen deficiency, if it is there, then you need to give cryoprecipitate. So if K time is more, you need to give FFP. If
This is a short.
What is R? R is usually 5 to 10 minutes. It is the time till initiation of clot formation. What is K value? Time to achieve 20 mm clot on assay, representing thrombin platelet interaction. What is alpha angle? Rate of fibrin cross linking, which is maximum amplitude, maximum strength of the clot. And what is LY30? Degradation of clot 30 minutes after maximum amplitude. So if we have a prolonged clotting time, prolonged R value, we need to give FFP. If the K value is less, we need to give cryoprecipitate or fibrinogen. If the alpha angle is less, we need to give cryoprecipitate or fibrinogen. If the maximum amplitude is low, means the platelet is the problem, so we need to supplement platelet or give desmopressin. And if LY30 is rapid, we need to, means the built-in clot is lysing too fast, we need to give anti-fibrinolytics like Trenexa and Amicar, epsilon amino caproic acid. As you can see, this is the normal. Then there is a hemodilution, so the R value is increased, the starting of clot formation is prolonged. Then if there is fibrinogen deficiency, then the K value is increased, 20 mm thickness clot का लेट से अचीव हो रहा है, साथ में अल्फा एंगल इज ऑल्सो लो, मीन्स फिब्रिन क्रॉस लिंकिंग ठीक से नहीं हो रही है. If the platelets are dysregulated, we will not achieve the maximum strength of the clot. If there is a मतलब थ्रोम्बोसिस ज़्यादा हो रहा है, तो we need to give एंटीकोएगुलेंट, क्योंकि इसमें फटाक से थ्रोम्बोस होके वो फैल जाएगा. प्राइमरी फिब्रिनोलाइसिस है, तो मीन्स क्लॉट तो बन रहा है लेकिन इट्स लाइजिंग वेरी क्विकली. LY30 इज़ वेरी लेस. 30 मतलब 30 में बहुत ज़्यादा क्लॉट, 30 मिनट्स में बहुत ज़्यादा क्लॉट लाइज हो जा रहा है, तो हमें एंटी फिब्रिनोलिटिक या ट्रेनेक्सा देना है. एंड देयर सेकेंडरी फिब्रिनोलाइसिस, ट्रीट द DIC. Next chapter, which is chapter number 14, is allergy and anaphylaxis. So what is anaphylactic and anaphylactoid? Toid means pseudo, मतलब ये उसके जैसा है पर वो नहीं है. So anaphylactic needs IgE, बाकी anaphylactoid no IgE. Okay. Hypersensitivity is an inappropriate immune response to generally harmless antigen. Anaphylaxis is a severe form of hypersensitivity. Anaphylaxis represent the most dramatic and severe form of immediate, which is type 1 hypersensitivity. So hypersensitivity is 4 types. Anaphylaxis is a severe systemic features and type 1 hypersensitivity. What is the clinical criteria of anaphylaxis? So there are 3 criteria. First is there is skin manifestation like urticaria, itching, flushing, edema of the tongue and uvula developing over minutes of 2 hours with one of the following. Either there is respiratory distress and hypoxia, or shock, or symptoms of organ dysfunction like hypotonia, syncope, incontinence. So basically respiratory, cardiovascular or neurological compromise with skin allergy findings developing within minutes to hours. Second is 2 or more sign or symptoms that occur minutes to hours after allergen exposure. So you have a history of some allergen exposure, like 2 out of these 4, more than equal to out of these 4 needs to be present, which is skin or mucosal involvement, respiratory compromise, hypotension and GI cramps or vomiting. So yeah, vomiting is a sign of anaphylaxis. Third is consider anaphylaxis when the patient is exposed to a known allergen and develop hypotension without any other explanation, like some bees developing hypotension after bee or hymenoptera sting, और पीनट खाने के बाद शॉक हो गया, या किसी मिल्क एलर्जी पर्सन को मिल्क खाने के बाद शॉक हो गया. These are some common causes of anaphylaxis. Drugs में बीटा लैक्टम एंटीबायोटिक्स, एस्पिरिन, कोट्राइमोक्साजोल, वैंकोमाइसिन, एनासिड्स, any drug basically. Other is bee sting, insect part, mold, radio contrast material, vaccine, latex, blood products. Then there is food, shellfish, soybean, nuts, wheat, milk, eggs, aspirin seeds, mammalian meat. Anaphylaxis occurs due to activation of mast cells and basophils, increasing the IgE as well as histamine, which increases histamine tryptase, carboxypeptidase A and peptidoglycan. There is activation of phospholipase A2, then cyclooxygenase, lipoxygenase, increase leukotriene, prostaglandin, inflammation. Histamine causes vasodilation, increase vascular permeability, heart rate, and increase cardiac contraction, glandular secretion, causing our skin and lips to swell, itch, and increase secretions. Prostaglandin D2, find it PGD2, it is a bronchoconstrictor, pulmonary and coronary vasoconstrictor, and peripheral vasodilator. Platelet activating factor PAF is also a potent bronchoconstrictor, especially PAF4, TNF alpha, and everything cause anaphylaxis. It is very fast. In fact, 50% of anaphylactic fatalities occur within the first hour. If the patient does not have any symptom, don't just send him, because the second bout of recurrence can occur 8 to 11 hours after the initial exposure. The diagnosis is purely clinical, and a good history of any allergens exposure, because you may then confuse it for some anxiety, some asthma, some skin reaction, some vomiting, gastroenteritis. So don't do it. Give ADR in a patient who is going into shock very fast. There are massive differential diagnoses like vasovagal reaction, MI, dysarrhythmia, asthma, seizure, epiglottitis, hereditary angioedema, foreign body obstruction, carcinoid, mastocytosis, vocal cord dysfunction. The most common imitator is vasovagal reaction. उसमें भी sudden hypotension, pallor, bradycardia, sweating होता है. You can send lab investigation, but they are not much useful, like serum histamine levels maximum at 30 minutes and serum tryptase level, they are elevated for several hours. Adrenaline, I need you to listen to me. Adrenaline is a pan alpha and beta stimulator. It is a wonder drug in a sense. Alpha 1 action causes vasoconstriction, thus reducing edema and increasing the BP. Beta 1 action will increase the heart rate, increase heart contractility, and beta 2 will cause bronchodilation and it will stop the histamine. What are the clinical manifestation of anaphylaxis? So in ENT there can be oral tingling, itching, numbness, edema or fullness. Respiratory patient can have a short of breath, feel like a lump in the throat, stridor, rhinitis, rhinorrhea, bronchorrhea. In cardiovascular, he can say a chest pain or hypotension. Skin mein there is urticaria, angioedema, flushing, itching. GI, nausea, vomiting, cramps and diarrhea. Neurological, there can be headache, seizure and hypotonia. All anaphylaxis patient go to red area. The treatment में first line therapy is epinephrine, oxygen, decontamination and IV fluids. So airway stabilize करना है. Examine the mouth, pharynx, neck for any stridor, respiratory distress, angioedema. So examine the mouth, pharynx and neck for signs or symptoms of angioedema, uvula edema, hydrops, audible stridor, respiratory distress or hypoxia. If angioedema is producing respiratory distress, intubate early, since like in burn cases and in anaphylaxis cases, you may not be able to intubate after the edema has obstructed the airway. So you need to do it fast, early in fact. For decontamination, gastric lavage is not recommended. Remove any remaining stinger which is used to inject venom, because stinger continues to inject venom even if it is detached from the insect. Use epinephrine. This is a wonder drug. It was created for basically our survival from anaphylaxis, so use it. It is underused, underprescribed. In patient without signs of cardiovascular compromise or collapse, you need to give IM epinephrine every 5 to 10 minutes. IM dosing is recommended because it provides higher and more consistent rapid peak epinephrine than subcutaneous. So what is EpiPen? EpiPen में 0.3 mg epinephrine होता है for adults, and there is a EpiPen Junior also, which contains only half the dose, 3.3 mg का half the dose, 0.15 mg for children less than 30 kg. Age is not a barrier to epinephrine IM injection in patient with anaphylaxis. If the patient is refractory to treatment despite repeated doses, the BP is not increasing despite repeated doses of IM epinephrine, and to use IV bolus and infusion of epinephrine. Initial dose is 100 microgram over 10 minutes. Start your infusion at 1 microgram per minute and stop immediately if arrhythmia or chest pain occurs. We need to give fluids, crystalloids in this. No albumin or hypertonic saline helps. So fluids basically, no nothing fancy albumin or hypertonic saline. Epinephrine has a very short half-life, about 5 minutes maximum, IV epinephrine. So in anaphylaxis, the first line therapy are epinephrine, oxygen and fluids. Epinephrine IM dose is 0.3 to 0.5 milligram, or use an EpiPen. If you're giving IV, give 100 microgram over 10 minutes, then 0.1 microgram per minute. 0.1 microgram per minute, and then titrate it up or down to effect. Oxygen देनी है accordingly, fluid देना है. Second line therapy we can use Avil, diphenhydramine, Rantac, cimetidine and steroids. We can further add salbutamol, ipratropium and Maxelf to counter the bronchospasm, and we can give glucagon in patients suspected of beta blocker injection. 1 milligram IV every 5 minutes, then 5 microgram per minute infusion. Glucagon dose is 1 milligram IV every 5 minutes. When we are discharging the patients of anaphylaxis, we need to educate about the EpiPen and to avoid the allergen. Identify the inciting allergen if possible. and allergy tag tests. And prescription, what we will give, we will get diphenhydramine and corticosteroids. We will at least give them 2 epinephrine auto injectors, blue to the thigh, orange to the thigh, blue to the sky.